Today, Alicia and I will be discussing gastrointestinal diseases. We will be going over the following topics. We will describe gastrointestinal disease and state its relevance to the practice of dental hygiene, describe the etiology of gastrointestinal disease, the signs and symptoms, the medical management and dental management, and treatment planning and considerations. Gastrointestinal disease is a disease that affects the digestive system. This system breaks down food in order to absorb water and extract nutrients, minerals, and vitamins for the body's use, while then removing unabsorbed waste. A gastrointestinal disease affects the body's ability to transport nutrients and remove waste through the GI tract. Some gastrointestinal diseases include peptic ulcers, inflammatory bowel disease, and pseudomembranous colitis. A peptic ulcer is a well-defined break in the gastrointestinal mucosa. This results in chronic acid and pepsin secretions and the destructive effects of the body's response to Helicobacter pylori. These ulcers develop in regions of the GI tract that are near acids and pepsin secretions. They are one of the most common human ailments. The etiology of PUD is Helicobacter pylori. It's a gram-negative helical-shaped bacteria that has evolved to penetrate the mucous linings of the stomach and establish infection. More than 80% of duodenal and gastric ulcers in the U.S. are caused by Helicobacter pylori, and 90% in other parts of the world. H. pylori is only found in humans. It's adherent but non-invasive. It resides between the surface of the gastric epithelium and overlying mucus gels. It produces urease and hydrolyzed urea to ammonia and carbon dioxide. The use of nonsteroidal anti-inflammatory drugs is the second most common cause of PUD. Other risk factors include advanced age, physiological and physical stress, acid hypersecretion, cigarette smoking, use of certain drugs, major comorbid disease, and cystic fibrosis. Some patients may experience no symptoms of the disease. Others may experience long-standing epigastric pain, burning, gnawing, aching, sharp localized pain in the stomach, and discomfort of a duodenal ulcer manifests most commonly on an empty stomach and frequently awakens the patient in the middle of the night, and it's relieved after eating. Medical management is dependent on the patient's condition. If the ulcer is confined uncomplicated without the presence of H. pylori, anti-secretory drugs are prescribed. This is a proton pump inhibitor that is taken for 10 to 14 days. If H. pylori is present, then triple therapy is prescribed. This includes inhibitors of gastric acid secretion and 2 antimicrobial agents. PPIs are taken for symptom relief and accelerated healing. The 2 antibiotics are used to eradicate H. pylori. The patient will take these medications for 10 to 14 days. As well as prescribing medication, the physician may also take the patient off of ulcerogenic factors that may increase their chances of developing an ulcer. The dental provider must identify symptoms through a careful history that is taken before dental treatment. Many gastrointestinal diseases, although they are chronic and recurrent, may remain undetected for long periods of time. The clinician should review medications thoroughly, including looking for aspirin and other nonsteroidal anti-inflammatory drugs, as well as oral anticoagulants the patient may be taking, as well as the level of alcohol consumption that may lead to gastrointestinal bleeding. If gastrointestinal symptoms are suggestive of active disease, a medical referral is needed. When prescribing medication, aspirin and aspirin-containing compounds and nonsteroidal anti-inflammatory drugs that may cause ulcers should be avoided. Antibiotics used for dental treatment may need to be adjusted based on the antibiotics used recently in treatment of PUD. Dosing of anesthetics, benzodiazepines, and antidepressants that are metabolized in the liver may require adjustments as well. H. pylori is found in dental plaque and may increase the patient's chances of infection. More frequent recares should be appointed in between cleanings, as well as good oral hygiene practices at home should be enforced to reduce the patient's chances of furthering their ulcer with H. pylori in their dental plaque. Antibiotics can also lead to oral candidiasis. PPIs used for treatment may alter the patient's taste perception. Vascular malformations on the lips may develop. Erosions to the enamel may develop due to gastric acids in the mouth. Xerostomia can develop in the patient due to medication use for treatment of PUD.
Okay, so the next type of gastrointestinal disease we are going to talk about is inflammatory bowel disease. So inflammatory bowel disease is a term that encompasses two idiopathic diseases of the GI tract. The first one is ulcerative colitis, and then the second one is Crohn's disease. So there's also a criteria that it separates the two diseases, which are site and extent of tissue involvement. For ulcerative colitis, it is a mucosal disease that is limited to the large intestine and the rectum. And for Crohn's disease, it is a transmural process that may produce patch-like ulcerations along the alimentary canal from the mouth to the anus. As for etiology, like I said before, it is idiopathic, which means that it is of unknown cause, but it is thought to be associated with immune dysfunction in response to environmental factors in people that are genetically susceptible. So first, for ulcerative colitis, it is an inflammatory disease that targets the large intestine, and it is characterized by remissions and exacerbations. It starts in the colon and rectum region and can spread proximally to involve the entire large intestine. It is a lifelong disease. There is no cure, and it can progress to more severe forms that predisposes a person to toxic dilation and dysplastic changes known as carcinoma of the intestine. So you can see here in the photo that the first intestine above is a normal intestine, and then the ulcerative colitis, you could see that there is inflammation within the large intestine and colon. As for Crohn's disease, it is a chronic relapsing idiopathic disease. It is characterized by segmental distribution of intestinal mucosal ulcers called skip lesions. It is located in the distal ileum and proximal colon, where it is most affected frequently. It affects the entire bowel wall. It is non-continuous regions of thickened bowel wall, irregular glandular openings, mucosal fissurings, ulcerations, erosions, and relapse is more common in tobacco smokers. So you can see here's a picture of the normal intestine and then an intestine that is affected by Crohn's disease. As for signs and symptoms for ulcerative colitis, patients will experience attacks of diarrhea, rectal bleeding, abdominal cramps, dehydration, fatigue, weight loss, fever, arthritis, eye disorder, and growth failure. For Crohn's disease, patients will experience recurrent, persistent diarrhea with or without blood. Their right lower quadrant will experience abdominal pain and cramping. They will might experience anorexia, weight loss, unexplained fever, malaise, arthritis, but also symptoms are variable. As for medical management, there is an array of drugs that are used to manage ulcerative colitis and Crohn's disease, but it is not curable. So the first line of treatment would be antidiarrheal and anti-inflammatory. The second line of treatment would be immunosuppressive agents and antibiotics. The third line of treatment will be in a Crohn's disease person who are refractory to steroid treatment would be biological agents. There's also supportive therapy used to manage these conditions, which is bed rest, dietary manipulation using fish oil, and nutritional supplementation. Okay, as for dental management, antibiotics might be needed on people who are on immunosuppressive therapy because they may be at increased risk of infection. If antibiotic pre-medication is provided, we want to make sure that we minimize the use of clindamycin if possible. As for appointments, only urgent dental care is advised during acute exacerbations of GI disease. Otherwise, we would want to schedule the patient during periods of remission. Bleeding is generally not an issue unless a flare-up is accompanied by thrombocytopenia or if the patient is on immunosuppressant drugs that cause thrombocytopenia. As for capacity to tolerate care, the use of steroid drugs may be a clinical concern because corticosteroids suppress adrenal function and reduce the ability to withstand stress. It is still recommended that their patient takes their usual dose of corticosteroid before dental appointment, and the dentist will provide additional pain and anxiety control. Supplemental corticosteroids may be required in rare circumstances. There's also drug considerations that need to be made. As for anti-inflammatories, aspirin and other NSAIDs are to be avoided, and as for immunosuppressors, they are associated with the development of pancytopenia, so a thorough head and neck exam should be performed. As for treatment planning considerations, only urgent dental care is advised during acute exacerbation, otherwise treatment should be scheduled during time of remission, and it is also important to assess the severity of the patient by taking their temperature to make sure that there is no fever, and asking them the number of diarrheal bowel movements they experience in one day, and asking them if there is presence of blood in their stool. It is also important to be flexible when making appointments. As for oral manifestations we see in people with inflammatory bowel disease, we see aphthous-like lesions in patients that have ulcerative colitis, usually during times where they have GI flare-ups. They're usually located on the alveolar, labial, and buccal mucosa, the soft palate, uvula, and retromolar trigon. Pyostomatitis vegetans is a raised papillary vegetative projections or pustules that are on erythematous base, usually located on labial mucosa, gingiva, and the palate, which is in the picture you see right here to the right. We also see atypical mucosal ulcerations with diffuse swelling of the lips and cheeks. The next disease we're going to talk about is pseudomembranous colitis. It is a form of colitis that results from overgrowth of C. difficile in the large colon. So overgrowth results from a loss of competitive anaerobic gut bacteria due to the use of broad-spectrum antibiotics, heavy metal intoxication, sepsis, and organ failure. This disease can be severe and sometimes fatal. Clostridium difficile produces and releases potent enterotoxins that induce colitis and diarrhea. The etiology is Clostridium difficile in 90 to 99% of pseudomembranous colitis cases. This bacteria is a gram-positive spore-forming anaerobic rod. It is found in sand, soil, and feces. It could survive on contaminated surfaces for months and is relatively resistant to many disinfectants, and it colonizes in the gut. Disease risk increases when broad-spectrum antibiotics are used for a prolonged amount of time. As you can see here, there are certain antibiotics that put you at higher risk, and then there's more antibiotics that are less frequent. As for signs and symptoms, the course of illness is variable, but diarrhea is most common. In mild cases, the stool is watery and loose, and in severe cases, the patient might experience bloody diarrhea, abdominal pain, cramping, fever, dehydration, metabolic acidosis, hypotension, peritonitis, and toxic megacolon.
The first-line treatment of pseudomembranous colitis involves the discontinuation of use of the offending antimicrobial agent, along with introducing an antibiotic that will eradicate the toxin-producing C. difficile. With moderate disease, 500 milligrams of oral metronidazole, or Flagyl, is used 4 times a day for 10 to 14 days. 125 to 500 milligrams of vancomycin is prescribed 4 times a day for 10 to 14 days, and it's recommended for patients whose whose disease is severe or unresponsive to metronidazole. C. difficile spores can survive treatment and relapse can occur in more than 20% of patients. Hydration and IV fluids are used to correct electrolyte and fluid imbalances. When recurrences occur, vancomycin, fidaxomicin, and rifaximin, with or without probiotics, or alternatively with fecal bacterial therapy, are prescribed. The dentist should be aware that pseudomembranous colitis has been reported after short-term use of clindamycin in the American Heart Association prophylactic regimen. The clinician should avoid the use of clindamycin, ampicillin, cephalosporins. The patient's risk increases with the amount of antibiotics used in association with pseudomembranous colitis. Antibiotics should be prescribed when necessary and the duration should be limited. Elective dental care should be delayed until the case is resolved. The medications used for treatment may cause oral candiditis. The use of metronidazole may cause peripheral neuropathy, nausea, and metallic taste.